from my personal experience, thinking back 20 years ago or so, back when there was lifetime caps before the Affordable Care Act came into play, even though I was personally treated at a Hemophila Treatment Center, there was a lot of pressure to manage those lifetime cap dollars, and it really affected my care personally. For example, a practical example would be reducing the dose of factor. What was the minimum tolerated dose that would effectively treat a bleed? And it probably gave me some suboptimal care early on. So as I've seen some things like the Affordable Health Care Act take place and the elimination of lifetime caps and some of the worry with pre-existing conditions and actually obtaining insurance, kind of from a patient standpoint, it takes some of that pressure off, that you don't have to think as much about the financial aspects of your care, and that you can actually now have support to obtain the appropriate dose through your HTC. So that's one thing. And I think that the ways that all this can be improved upon is through treating patients at their Hemophila Treatment Center, improving documentation from a patient standpoint of their bleeds, and really trying to get the patient through the HTC to be kind of the primary member of their treatment team to help us actually have objective data to make treatment decisions is one thing that I think can continually be improved upon. And I know that payers are now looking more and more at patient documentation, and it's not just for data collection anymore for studies and things like that. It's also for looking at cost of utilization and how well are patients adhering to their regimen and how effective is it at treating their bleeds. And as we get patients more and more on board with actually giving us good data and documentation of their prophylaxis usage, of their use to treat bleeds, then we're actually able to tailor their therapy much better. And ultimately it ends up for the payers too, to have cost savings, because you take some of the guesswork out when you actually have objective data to look at for treating your patients. So those are a couple things that I'm seeing, how things have changed over the last couple decades. For the communication methods and tools for the health plans, I think it really starts with education of the different insurance providers to know a little bit about the pathophysiology of what is hemophilia and what people living with bleeding disorders, what are their daily struggles. I think it's important that, especially because with this disorder, there's such a high cost associated with treatment, I think it's worth the individual health insurance plans to have some sort of designated specialist who can kind of be the contact person and oversee and become educated on hemophilia and various bleeding disorders and their treatment. And I think in a large part that as they begin to see more and more the federally recognized Hemophila Treatment Centers across the nation as the medical homes for patients with bleeding disorders, and that we really, the provider at a Hemophila Treatment Center, we are really their collaborators in trying to take care of people with bleeding disorders. So I think if it starts with them getting some better education, which I'm hearing from my colleagues is that's starting to happen more and more, I think that that's something that can help align the health plans with the HTCs, and really that they should recognize that providers at the HTCs are experts in the bleeding disorders, and we actually have data from the Comprehensive Care Sustainability Collaboration showing that those patients that were taken care of at HTCs compared to hemophilia patients taken care of at other institutions had a relatively lower mortality and relatively lower number of hospitalizations if they're taken care of at an HTC. And so we actually have data. I think that the relative mortality for those not taken care of at HTCs was 1.7, and the relative number of hospitalizations, the relative risk was 1.4. So increased if you were not at a Hemophila Treatment Center. So I think that as payers see the data that we're collecting, and they see that really we are kind of on their side to manage healthcare dollars as appropriately as possible for those with bleeding disorders, I think that they will be very interested in having their patients further managed by the Hemophila Treatment Center model, and that we really are the medical home for patients with bleeding disorders. If I was talking to senior management of a health insurance plan, we'd actually, from my center at the Bleeding and Clotting Disorders Institute in Peoria, Illinois, we actually have data to show that versus other patients treated at other centers or receiving their factor through non-HTC pharmacies, that we actually save our patients money when they're actually taking care of the Hemophila Treatment Center with a 340B model. Basically, that is a federal program that allows Hemophila Treatment Centers to sell factor at a reduced cost to their patients that basically can use those proceeds to actually fund the nonprofit federally recognized Hemophila Treatment Centers. And so we actually have data to show that patients that receive their factor from us, and we are their advocates, we are their medical home, we actually reduce the cost to the payers for what the factor costs for those individual patients. So usually there's a therapeutic range that, in general, I think across the nation, people will accept plus or minus 10% based on weight for certain factor dosages. And I know at our center, we keep our patients within plus or minus 5% of their factor doses, and we actually have, over the last couple of years, data to show that more than most centers in the country, we actually do the best job at cost utilization, and then we also have data to show that our patients are treated far superiorly at our Hemophila Treatment Center than when they're treated at other places. So really, talking to senior management, what I envision is that really patients with hemophilia and other bleeding disorders, really it should be strongly advocated to be treated at Hemophila Treatment Centers. Because myself and my colleagues at my center, we've dedicated our careers to treating people with bleeding disorders. So we know the up-to-date evidence-based treatment guidelines. We have a multidisciplinary team to treat our patients in every aspect of their life, in addition to just their hemophilia. We have physical therapists and social workers and dentists, nutritionists. We have a whole comprehensive care team. So really, if the senior management of a health insurance company has objective data to look at and says, my gosh, I mean, look at how well they're taking care of it in HTC, and we can do it for lower cost than if we're taken care of by a non-specialty center with a non-specialty HTC pharmacy, then it makes financial sense. It makes sense in every regard for patients to be treated at a Hemophila Treatment Center that's federally recognized. The key for a managed care organization to adopt would be to mandate that patients with hemophilia and other bleeding disorders are treated with a Hemophila Treatment Center as their medical home. And I think, especially in this day and age, is we have data to show that their treatment is most optimal and most cost efficient when they're treated at a Hemophila Treatment Center. So I think really that should be something that is eventually just mandated with different payers across the country. I mean, that's my opinion, but I mean, we also have data to back that up. I think that's something that the managed care organizations really need to look at, and then also look at just the financials of how our 340B program works. I mean, really, it's a beautiful story in hemophilia treatment care that we actually have a mechanism, especially in the days as a physician that are worrying about seeing volume of patients and RVUs and all these different things. Well, really, if you have the 340B program to help fund your center, then you don't have to worry as much about seeing patient volume, and you can really spend time one-on-one with your patients. And that's the nice thing about being at the center that I'm at. We can have patients that spend up to an hour or more sometimes with a treatment provider at a routine visit to talk about every aspect of their life, and we can do that because of the funding mechanisms that we have, and it can relieve some of the pressure from us as physicians for seeing volume of patients. It's more about the quality of care for the individuals, and it allows us to maintain really being at the forefront of research efforts and collaboratives nationally and taking care of patients. It's a really good package for patients when they're treated by a hemophilia treatment center. I think that having dedicated hemophilia bleeding disorder liaison at each insurance company that is easily accessible by the HTCs and that's educated and really is a patient advocate at the individual healthcare organizations, I think that would streamline things a lot, because I know my nurses spend hours and hours of their day sometimes trying to talk back and forth with insurance companies, and people are unfamiliar with what hemophilia is, and it really ends up being a big headache in trying to get our patients pre-authorized for the different procedures that they need, for the different therapies that they need, et cetera. So I think that would be the biggest thing I'm hearing from my nursing staff would be if there was something who became familiar with the treatment of hemophilia at every organization, because again, I think that the cost of the different organizations to train such an individual would be minimal compared to the benefit that it would offer the bleeding disorder community. So I think that would be something that would make the pre-certification and prior auth process much more streamlined. And actually then there's not a lot of back and forth, and that they actually believe what the Hemophila Treatment Center is telling them, because this is what we do every day, all day. So I think the key job responsibilities of a dedicated contact would be, one, they need to have some background education and understand the pathophysiology of hemophilia, and also a little bit about its history, because I think really to appreciate how far we've come in the last 30 years or so in hemophilia treatment, they need to understand the nuances of this population, how many of us personally who have hemophilia were touched by the HIV outbreak in the 1980s, and how basically hemophilia providers and really the pharmaceutical industry worldwide responded, and look at how well they've taken such a really a devastating disease, and in the past few decades have really revolutionized its treatment. I think that that individual would first need to have some dedicated education, and then really they would need to be educated on the Hemophilia Treatment Center model and how it works, and the data to show superior outcomes and cost savings and all of the other things we talked about. And really just that someone that when one of our patients has a need at an individual company, that there is a direct line access phone number, someone who would be easily available, or maybe even a team of people that were easily available that we could reach out to get the approval and things paid for that we need to for our patients. I've talked with my nursing staff about this before, because at our center they're the ones that actually do a lot of the filling out of the prior auths, and they tell me that every form from every provider is different, and there's so much variability in the amount of information that is required. And then there are some companies that almost always will reject their requests even when the prior auth form is filled out completely, and then it ends up needing a follow-up letter from a physician. So there's a lot of time involved, and it'd be nice if the insurance companies would believe what we're telling them is necessary, because we have data to back it up, the requests that we're making for our patients. So I don't know if there's really something necessarily in a standardized form logistically, I mean, other than what the patient has, what procedure or treatment we're recommending, and why. But it should be streamlined when information is provided that it's approved in a timely manner without needing follow-up letters from the individual physician. So I don't know if I have specific recommendations for the standardized form, but just that the companies would really believe what we're telling them is necessary, and approve things without follow-up forms and letters being required. Cooperation of all parties to get this vision in place. You know, I think from the patient perspective, there really needs to be advocation that they are compliant with record keeping, et cetera, because the way these changes happen, right, is if we actually have data to show that the therapies that we are recommending make actual clinical impact. And that's probably one of the most difficult things as a provider to do, is to really assess how many bleeds have you been having since your last visit. Are you accurately keeping records? And I actually spend time and show my patients what I use personally, the Ath and Advoy app, and show them, look, people are making this really simple. It's not how it used to be, the days of paper logs and everything like that. So, but that takes time, and not all patients are accommodating as others. But I think there needs to be a patient education move, that they need to know that really to take care of them optimally, we really need this data captured. So I think from a patient standpoint, that would be great. I think from the insurance company and HTC, education of the payers, I think, is key, because they really need to know what outcomes are available for the people with hemophilia and other bleeding disorders through the HTC model. So as more and more collaboration can happen between the HTCs and insurance companies and even patient organizations and keeping accurate records, things like that. So I think that's kind of the most important first step, is the education. And then I think improving the HTC 340B pharmacy capabilities nationwide to make sure that hemophilia treatment centers across the country are all keeping up to date on the latest data and the best treatment modalities, and really improving the collaborative network, which needs to be more uniform across the country. I have colleagues across the nation that if I have a patient moving to a new location, et cetera, I can reach out to and give them their medical history, and I know they're going to be in good hands because they're at a center that's similar to mine and they have similar outcomes. So I think improving that collaboration between the HTCs nationwide, which I know is happening. And so really I think just more and more just improving the national infrastructure of collaboration with various insurance providers, HTCs, and patients, which, like I said, I think we're seeing that happen, and it just needs to continue, and more people need to get on board and get excited about it and know that if we all work together, that we're going to give our patients the best quality of life and ultimately move towards patients that don't experience bleeds.